Okay, good afternoon, everybody. My name is Moosa Naduvil. I'm one of the pediatric epilepsy staff physicians. I work closely with Dr. Ahsan. I run the Ketogenic diet clinic with our dietitians and the nurse team. I'm happy to be here to talk to you about the role of ketogenic diet in general in epilepsy, and in particular about what we know in children with CDKL5. Okay. Given this title, ketogenic diet since 1920s, I'm sure CDKL5 was there, and we did not know. We probably knew that only a couple of decades ago here. I wish to handle this topic under these following sections here. Number one, I've been using it for more than 100 years. We had more than 30 plus odd seizure medications in the market. Why do we still use it? How did we start using it? Since I'm talking to you, not necessarily a medical audience, even though you guys are very, very well informed about this condition in particular and palliative therapies and this, I'm going to use more into the history and some common aspects of the diet rather than too much into the scientific aspects of the diet. And some broad strokes about how effective is the diet in general as well as in children with CDKL5. And how do we know, what do we know about the use of diet in CDKL5 and what are the side effects? Okay. I was told that it's a 30-minute talk, so we will try to do it around 25 minutes and see if you have any questions. I can take it. So the diet came into practice or use in the 1920s. If we go back to 1920s, we had only two things available for treatment of epilepsy. Bromides have been there for a long time, since 1800s, and phenobarbital came to market in 1912. Okay. The next medicine to come to market was phenytoin, that was in the mid-1930s. Okay. So there was a huge gap there, and as you know, epilepsy is not controlled frequently, about a third of them do not get controlled with medication, so there was always a need for additional options. So the use of ketogenic diet, the concept of ketogenic diet probably came in the late 1910s, 1920s is the time of the publication. This was a physician, as an osteopathic physician, Dr. Hugh Conklin. He was also a faith healer. And the rationale he had for using ketogenic diet, and by the way, it was not ketogenic diet, it was basically fasting patients for a long time. Given only some low-calorie fluids and liquids, even fluid restriction. Obviously, these patients have frequent daily seizures, and by fasting them for a long time, minimally hydrating, minimally giving calories, there was a substantial reduction of seizures in the patients we treated. His theory was seizures are caused by toxins in the gut, and you rest the gut, put the gut, it's like a detox kind of a thing. So put the gut to rest and then the seizures get better. That was his theory. Around the same time, there were scientists who were working on this, the idea of this fasting leading to improvement of seizure control. And of course, fasting, you cannot fast forever, you have to have some kind, 1 year to eat. And can we reproduce the chemical changes that happens in the body during fasting without fasting? Can we do it? What happens to your body composition? What kind of chemical changes that happens with the fasting? Can we create the same thing without fasting? And then they realized that we could do that by giving a diet that is very high in fat, very low on carbs. That's the key there. So you get a high ketone. When you have fasting, you get into ketosis. You are depleting the sources of carbohydrates, glycogen, and then the body shifts this metabolism into breaking down fat in the body. That's what happens in fasting. So instead of breaking down the fat in the body, can you give extra fat in the food and create the same kind of chemical changes in the body? Can we create that? And that's what happened with the ketogenic diet. So this was a publication from the Mayo Clinic. So the initial original idea of ketogenic diet kind of came from the Mayo Clinic. And subsequently it kind of refined and became more popular through Johns Hopkins in the mid-90s. So ketogenic diet, what is ketogenic diet? Before that, it's a good idea to look at what is a typical diet look like. The three major components of the diet are the fat, protein, carbohydrates. In a typical American diet, about a third of the calories come from the fat, and about 15 to 20% come from the protein, depending upon person's dietary habits. Maybe a typical average American diet may have a little bit more protein than this. And carbohydrates come around for nearly 50%. Again, depending upon ethnicity and the food practices, these ratios will vary a little bit. In the ketogenic diet, and many of you may be familiar with the ketogenic diet. When we say ketogenic diet, a ratio of 4:1 means 4 is the grams of fat in the diet to 1 gram. The first letter stands for the number of grams of fat, the second letter stands for the number of grams of carbohydrate and protein. Okay. When you have a 4:1 ratio, 90% of the calories come from the fat, and only 10% of the calories come from the protein and the carbohydrates. Basically, we calculate how much is the protein needed for the body growth of that baby, and then we'll calculate the carbohydrates based on that and the other fat. Traditionally, most children will need around 2.5 to 3:1 ratio on the ketogenic diet. Some children could require up to 4:1 ratio. So as you can see, 90% of the calories come from the fat, okay, in the 4:1 ratio ketogenic diet. So the use of ketogenic diet really was much more popular in the 20s and 30s because we had only bromides and phenobarbital. And then the phenytoin came, and then the practice of ketogenic diet became very erratic. People who were experienced with ketogenic diet were not very easily available. And slowly the use of ketogenic diet kind of fell apart, just like many other treatment modalities in medicine. In the meantime, you see we have plenty of newer medications. We probably have 30 plus anti-seizure medications have happened. But still, ketogenic diet is still used because, one simple reason, despite the availability of multiple different medications. I'm not talking about CDKL5, I'm talking about in general epilepsy. Whether we use the old drug or the new drug, the people with uncontrolled epilepsy, or what we call drug-resistant epilepsy, has remained the same. About a third of patients who have all kinds of epilepsies, they are not fully controlled with medications. The newer medications are a little bit safer to use, easy to use, less interaction, less side effects. But unfortunately, in terms of the number of people benefited, this has not really budged over years. So, in the 90s, the diet came back. Just like I have a lot of respect for families with CDKL5 for the dedication and the efforts to bring their experience and expertise together to improve the care of children with CDKL5. The ketogenic diet also came back and was rebooted in the mid-90s, again driven by patients and families. It is said that for something to go viral, Hollywood support really helps. And this was true for ketogenic diet. Jim Abrams is an American movie director. Many of you may have watched some of his movies, especially Airplane is very popular. And if you like the kind of comedy of Airplane, it's really a hilarious movie. So his son Charlie Abraham had drug-resistant epilepsy, failed medication. This was in the early 90s or mid-90s. He also had some surgery, some kind of surgeries, large seizures. And then Dr. Freeman, is a neurologist at Johns Hopkins, used a ketogenic diet in this patient, and he became seizure-free. Yeah, long-term sustained control of seizures. And she has done remarkably well with the diet. So the family was really surprised that this option was never taught to them until It was brought up by Dr. Freeman. So they wanted to make sure that the families are well informed. And that's the time the internet is booming, their websites are coming. And they started the Charlie Foundation in 1994 and to improve the awareness and to provide information about ketogenic diet. In fact, he even made a TV movie, First Do No Harm, with Meryl Streep at the lead, about a family's journey through the use of ketogenic diet. It definitely had an impact, not just on the families, it had an impact on the physicians and the hospitals. The ketogenic diet became more routinely used. To have a special clinics for the ketogenic diet. If you look at the number of publications before 95 and after 95, that's the number of publications that is discussed in the American Epilepsy Society. Now it is kind of a standard of care for any comprehensive epilepsy center to have a diet clinic. So moving on to how effective is the diet for control of seizures. In general, about 50%, probably 40 to 50% of children benefit with the diet. When we say success or a clinical response, if there is a reduction of seizures by more than 50%, that's defined as a positive response. That's often taken as response in many drug trials, and we kind of use that similar scoring for the drug, the dietary treatment as well. Until 2008, we had only some limited experience, retrospective studies, case series. In 2008, this study had a randomized control trial. When you say randomized control trial, we have two groups of children with same kind of epilepsy matched or randomized, so to speak, so that they have the same characteristics. And one group was treated with the diet, the other group was not with the diet, and compare the response. That's what was done. This was a group of children with daily seizures without any changes in their other medications. And they documented that the diet compared to a regular diet or placebo, it was effective in reducing the seizures. 38% had more than 50% reduction in seizures, and about 7% had more than 90% reduction in seizures. Seizure freedom, unfortunately, is not a common occurrence, even in other people with other kinds of epilepsy. Okay. We'll come to CDKL5 shortly. So again, this is the first concrete evidence to say that ketogenic diet could be used in drug-resistant epilepsy. And there are several conditions. There is a consensus statement on ketogenic diet therapies that gets updated every 10 years. The last time it was done was in 2018. They list a group of conditions that is consistently benefited by the diet in majority of times. There is some moderately beneficial. If you look at the list, you probably have CDKL5 and several of them is listed there. I suspect that this, right now the CDKL5 is in the second column here. It might move to the first column because we have a lot more data to say that it could be useful. It may not be greatly beneficial, but compared to many other medical treatments, there are more number of patients who could benefit from the diet than the medications. But in the last 4 or 5 years, we have a lot of new publications about the experience of the diet in CDKL, in children with CDKL5 in particular here. So this is an experience of more than 100 patients. This was published by Dr. Lim and Dr. Olsen there. This is from the International CDKL5 Disorders Database. Okay. Of the 204 subjects whose data was available at that time, ketogenic diet has been used in 50% of children. And some improvement in seizures was reported in as many as 88% of them. Okay. Unfortunately, a third of them had side effects, which could be come to it later. The main concern, main issue was the benefit was not sustained over time, and that was probably the main reason for more than 50% of the times, even if they had a good benefit, some benefit in the initial but they will not sustain. Only a third remained on the diet on the last assessment. Okay. On an average, most children in this series have been on the diet for over 15 to 17 months at least. And many of them, the diet was started a little bit later, maybe average of median of around 4 to 5 years of age. So they were not very started very early. And this is another publication. This is Dr. Ahsan was the lead author here. This is from the CDKL5 Center, so for the 4 centers, the Cleveland Clinic, Boston, Colorado, and what's the 4th one? CHOP. Okay. So on this, 89 of the 177 children were tried on the ketogenic diet, and the data on the outcome was clearly available only in 44 patients, and 50% had more than 50% improvement in seizures. So that was the. So one of the suggestions in this study was what would happen if you start early in the night. There was another study that looked at epileptic spasms alone and looked at the response to the diet. And the epileptic spasms, we assessed the response at 3 months after being on full therapy. And if you had started the treatment early in the disease course, within 2 to 3 months of the starting of the spasms, about 20% of them could have a good response at 3 months after the diet. And in CDKL5, as well as in any epileptic spasms, any little benefit, we try to make the best out of whatever that is available. And recently there was another study which looked at, it's a meta-analysis, meaning it looks at data from multiple different studies. There is 12 retrospective studies and over 193 patients. And from they defined as a clinical responder rate, by which they mean parents or the physicians felt that the diet was useful. This was around 50% of the patients. And a definitive responsive rate, meaning that they had a good data on what is the diet, the seizure count before and after, and more than 50% reduction in seizures was clearly there in 18% of patients. Seizure-free was rare in some patients, but they did not really mention how long were they seizure-free. So it may have been 3 months or a 6-month period. We can skip this. There are certain conditions where ketogenic diet should not be used. There are some rare genetic conditions where babies cannot metabolize fat and they are prone for low blood sugar. Yes, you have some questions?
I was just curious of what those diseases were.
I'm sorry?
Just the name of them really quick?
Sure. Yeah, it's okay. So these are, there are some absolute contraindications and relative contraindications. The absolute contraindications are basically fatty acid oxidation disorders, meaning these are metabolic disorders in which the babies have trouble metabolizing fat. Okay, so obviously if you're going to give a high fat diet, you want to make sure that. Most of these conditions are screened by your newborn screening, and in children with CDKL5, the chances of having another rare disease is very less. We often do a screening study of carnitin before we start the diet for this reason. Okay. How long to try the diet? In general, one can see some response in most responders within 4 weeks after starting the diet. So one of the things I always look at is what happened when we started the diet 4 weeks at my 1 month visit. How was that response? If they had a good response, then I am more hopeful that I would like you to continue the diet. If they did not have a great response at 1 month, then I still try to wait until at least 3 months before I say, okay, the diet is not having a great effect. So minimum 3 months before concluding this response there. And how long can you do the diet? It's kind of, we use this general rule as the anti-seizure medications. We use it for 2 years if they are seizure-free kind of thing. In CDKL5, unfortunately, sustained seizure freedom for longer periods is uncommon. So if there is benefit, there could be continued for very long term. There is probably a small risk in increase in the risk for cerebrovascular or cardiovascular events like a stroke and heart attack kind of thing. Happens if they've been on the diet for a very long time, 2 decades, 3 decades. And not everybody have high cholesterol levels just because they are on a ketogenic diet. Okay. Only a third of them will have even a minimal increase in the cholesterol levels. The common side effects are constipation. Yes?
On cholesterol levels, do you find that that is made worse by heavy use of cream? In a lot of the keto books, they talk about 36% cream as like the basis for a lot of recipes. But wondering if that has in particular, the cream is related to cholesterol.
So only most of the times, majority of children, we do not see a significant increase in the lipid profile, despite because the body is metabolized. Okay, and even in children who are higher lipids, it tends to drop down after a year. That is also common. In terms of between the fats, there are certain fats they are more likely to have the lipids increase in cholesterol, just like what you're saying is a bit to cream. So if they have increased cholesterol levels, our dietitians will look at it, what can we do for a more healthier fat kind of thing. So that is true. So in terms of the side effects, GI intolerance, sometimes it can produce increase in reflux in a high fatty food. There is a slowing down of the stomach emptying, so there is higher chance for reflux. Constipation is a common problem. I have not run into any of these issues stopping me from using the diet. Okay, if they have a constipation, we give medications. Miralax could be useful, and some other medications to improve the bowel movements. Kidney stones, about 3% of children could have kidney stones on the diet, and we use a supplement called the potassium citrate. I think I have a slide on that. I'll come to that later. Sometimes too much ketosis, if they are sick, sometimes they can go into too much ketosis. We have to check if they are flushed and repeated vomiting, lethargic, we check the ketone levels and see if there is more than the expected range. Occasionally you could have some increase in liver enzymes. Many times it's related to concurrent medication than the diet alone. And the countering the side effects, we have to ensure that the children are receiving enough multivitamins. Okay. If they are on a formula, most of the time the formula comes with the fortified vitamins. You don't have to be worried, but still our dietitian will calculate, is it meeting the daily requirement, do we need to supplement? The multivitamin tablets also have trace elements, so children with restricted diets could develop deficiencies, so we keep an eye on that. The potassium citrate is used to reduce the risk of kidney stones, and with the regular use of potassium citrate, almost the risk of kidney stones is essentially abolished in most of the centers. Okay? Otherwise, it's still around 3%. As I said, the laxatives could be used, and we also assess the need for other supplements. About 1/5 of them could have cognitive deficiency. And rarely zinc, selenium, copper, we check the levels to see if there is any replacement needed. I think we have a few more minutes left there. With regard to less restrictive diets, okay, if they are eating by mouth, can we have a little bit liberalize the diet? The traditional ketogenic diet, you're counting the carbs are very little, even the protein is very little, so there is a lot more fat, just like you're saying, whipped cream and avocado kind of thing. So can we improve the variety? And we have two different options of a modified diet. One is called the modified Atkins diet. Then when you say Atkins diet kind of came to use as a way to lose weight. That if you Google Atkins diet, you will see a lot of people, bodybuilders using the diet. Modified Atkins diet is a term used for use in epilepsy. In this modified Atkins diet, we still don't encourage too much of protein. We still encourage a lot more fat than the protein. The goal is not to lose weight. The goal is for reduction of seizures. As you can see, the traditional ketogenic 4:1 ratio, the fat is 90%, the modified Atkins is around 64%. Still, it's a very restrictive diet. You are having only some 30 grams of carbohydrates per day. You have a lot more protein options available in the modified Atkins diet, but still it is a restrictive diet. LGID stands for low glycemic index diet. Basically, the patients are asked to avoid food that would cause a spike in the blood sugar. Refined sugar, it's going to spike 100%. So there is an index for each and every food which has got carbohydrates. For example, brown rice is probably 50 compared to white rice is 90. In low glycemic index diet, we like to restrict the food with a glycemic index of more than 50. Okay? So avoid food with more than 50 as a glycemic index. Even then, will around 60 to 80 grams of carbohydrates will be there in the diet, also. It's kind of a healthier version of it. In general, most people could follow the diet. There is a 60% of the calories come from fat. If you do a lot more fat, it will be closer to the other diets. Okay. So this is a little bit more doable, especially children who are eating by mouth and enjoy different taste, and these kind of variations of the diet would be very useful. Initiating the diet, it is a medical decision. It's best, especially in young children. It's very important to have supervision, especially with the more traditional diets. The low glycemic index diet, I still do not recommend. If somebody has epilepsy, it's better to have a team that is guiding them. Otherwise, you could have some deficiencies that could be problematic. In our center, we have a keto team. We run our clinic on Monday afternoons, and so I meet with the patients. CDKL5 patients, they see Dr. Pastana, and Dr. Pastana decides, okay, we should try diet. They come and meet me and the dietitian, and we go over the risks and benefits, and we have an outpatient nurse who coordinates the care. So our dietitian does most of this work. My job is mainly counseling and supervision, making sure that we are not we are not choosing wrong candidates. We are making sure that patients are safe on the diet, not developing any medical problems that lead to complications. So the key takeaways are about 40 to 50% of children on ketogenic diet experience reduction in seizures. Okay, this is probably true in general, and maybe a slightly lower number for CDKL5. And from the large series that reported treatment in children with CDKL5, over 50% of children have been treated with ketogenic diet. Okay, so it's a commonly used therapy in children with CDKL5. I recommend at least a 3-month trial of diet is sufficient to decide the diet is effective or not. Again, sometimes I may be following up for more than a year or two, and sometimes the families may have struggled knowing whether the diet is really beneficial. They want to come off, and I usually go back to the first month visit, second month visit, third month visit, and try to see what was the benefit. If there was a definite benefit at that time, we may continue the diet a little bit longer. If there is no benefit, then when they get older and they are enjoying different kinds of food, we should let them do it. We should not bind them to the diet if it is not as effective. Adverse effects are mild usually. Generally, it's not a limiting factor in my opinion, at least in my experience. I never had to discontinue diet because of an unacceptable side effect in our practice. These are some of the resources, and that little handbook is from our Center for Our Patients. So there is a book, Ketogenic Diet and Treatment of Epilepsy by Dr. Kossoff. There is a team from Johns Hopkins. Its Kindle version is available for $10, I think. And the Charlie Foundation is a very important resource for many families. They give a lot of information about diet, implementing diet. There is a lot of activity goes on. Matthew's Friends is kind of a similar kind of website. I think it's UK based, I believe. And we use what is called a keto calculator. Keto calculator helps families to find recipes and use recipes. It's easy to key in the numbers. Okay, this much grams of protein is required, carbohydrate required, what kind of recipe, use the recipe. And the dietitian is also there. So the families, they prepare their own recipe and route to the dietitian. Dietitian go to the website, looks at that, okay, this is okay, go ahead and use it, kind of thing. So we teach them how to use the keto calculator so that it makes it easier for them. This is particularly important for traditional ketogenic diet. For the other two diets, such kind of rigorous calculation measurements are not required. Okay, I'm going to pause here and